All right, I am going to present a presentation on a framework I use for hyponatremia. Hyponatremia is one of the most complex topics, I believe, for like USMLE step 1 and step 2 because it uses a lot of physiology, a lot of pathophysiology, and it's tough when you haven't really seen it in the clinic a lot. I've done a lot of reading on hyponatremia, and I've seen it on my IM rotation. I've seen it in family medicine. I've seen it on a couple other rotations, and I had a really good attending who took the time to like kind of go through it. So I wanted to share kind of what I've learned and give you my schema for like how I think through things. It is the most common electrolyte abnormality you'll experience on the wards, and it's commonly tested on USMLE exams. So we'll get into it. So we're going to go through the schema I have for hyponatremia. We're going to go through it many times so you get it down. We'll consider different differentials we should have when we see a patient with hyponatremia. We'll look at some physical exam findings, to help us differentiate volume status. We'll integrate a little bit amongst other systems like I always do. And I've got an open-ended question for us at the end. So the basics, right? When I consider hyponatremia, that is a serum sodium less than 135. Usually sources will say less than 125 is going to be like your severe hyponatremia. Antidiuretic hormone, it's also called arginine vasopressin. That's our key hormone involved here. So remember, this is released from the paraventricular and supraoptic nuclei of the hypothalamus. It then gets stored in the posterior pituitary and then will get released, right? This is a common like step 1 question when they're asking you about both oxytocin and antidiuretic hormone. Remember, it's made in the hypothalamus, travels to the posterior pituitary where it waits, right? So be very careful and say, read, are they asking me where it's made or are they asking me where it's released, right? Because that's a classic question. So it's stored in the posterior pituitary, and then there's 3 major things that you want to know that will help release antidiuretic hormone. They are high serum tonicity, so like a high serum sodium level, low effective arterial blood volume, so low blood volume, and then pain, nausea, vomiting. So think about like post-surgery, post-trauma, okay? So again, the big 3, high serum tonicity, low effective arterial blood volume, and then pain, nausea, vomiting. So the decreased arterial blood volume is going to be the most potent stimulus for antidiuretic hormone. So that's even more potent than an increased tonicity or osmolality. The body is always going to prioritize blood pressure and perfusion over your serum sodium concentration. So I could have a patient who has a like serum sodium of like 120, right? Which would normally like stop antidiuretic hormone. Like we don't want any more antidiuretic hormone, but their blood volume might also be really low. And in that case, antidiuretic hormone will be stimulated because blood volume always beats serum osmolality. All right. So moving forward, this is a small but mighty topic that we need to talk about, is the difference between osmolality and tonicity. And they're not going to teach you this on Sketchy or, Boards and Beyond Epiphoma, right? But I'm going to teach it to you. So osmolality is the total concentration of solutes in the solution. So this includes all solutes, both my effective and ineffective solutes. So what is an effective or ineffective solute? An ineffective solute is a solute that is permeable across membranes. So that's something like urea. Urea is freely permeable across membranes, whereas an effective solute is only permeable in certain situations. So that's things like sodium, when it's got its sodium potassium ATPases activated, and things like glucose, where it's got insulin that drives it into cells, or it uses secondary active transport via sodium, right? So those like sodium and glucose would be great examples of effective solutes. Urea would be a great example of an ineffective solute. When I think about tonicity, tonicity is a concentration of my effective solutes only, right? So those that are going to actually pull water across the membrane, because at times they're not able to cross the membrane. And so them being on one side of the membrane is going to draw water across, right? Because they're very, very spongy, right? They're going to draw water towards them. So my question for you then is, how do we measure serum osmolality versus serum tonicity, right? So these are classic equations. I usually tell my students like not to worry too much about equations. This is one of the ones I would probably know for exams and for real life. I've used it many times in the hospital so far. But serum osmolality is going to be 2 times sodium plus glucose divided by 18 plus BUN divided by 2.8. And if you have a blood ethanol level, we can also add ethanol divided by 4.6. So that's taken into account all of my solutes, or like my big name solutes, okay? When I think about tonicity, right, that's only my effective solutes. So what did I tell you were the effective solutes? That's going to be sodium and glucose. So I just do 2 times sodium plus glucose divided by 18. So I've got that on this slide here. And we can just see, again, it's their equations I told you. And when I consider, right, urea is freely permeable, it's not effective. Glucose and sodium are impermeable in certain situations, so they are effective, right? So serum osmolality versus serum tonicity. Okay. So we're going to break it down now. A patient presents to the emergency department with some confusion and lethargy. A CMP demonstrates a serum sodium of 123, and they have a blood glucose of 90. So we'll forget about management now. That's going to be covered way at the end. How should we start working this patient up to find the etiology of their hyponatremia? So how would you like to start? So when I think about breaking down hyponatremia, I think about breaking it down based on serum tonicity. So serum tonicity should be calculated first. It's going to be 251 in our case, right? So just prove to yourself that you can do that. 2 times sodium, 120, so 2 times 123 plus glucose divided by 18, so that'll be 90 divided by 18. Make sure you can calculate 251. The serum tonicity can really be broken down into the following. Hypotonic is going to be less than 280 milliosmoles. Isotonic is going to be between 280 to 295, and hypertonic is going to be greater than 295 milliosmoles. Okay, so when I first get a patient who has hyponatremia, first thing I do is I calculate serum tonicity, and I can break it then down into, is this a hypotonic, which is going to be the meat and potatoes of most of my hyponatremia workup, or is this a case of hypertonic or isotonic hyponatremia? So I want you to, because the hypotonic is going to be the meat and potatoes of things, we'll quickly cover hypertonic, isotonic, and then we'll move on. So when I have a patient who has hypertonic hyponatremia, so again, a serum osmolality or a serum tonicity greater than 295, what are the major causes of hypertonic hyponatremia? So the big one you're going to really want to know is going to be elevated blood glucose. So that would be like glucose in the absence of insulin, because remember, insulin makes us now move across the membrane and into cells. So there is a formula. It's for each 100 grams of glucose above 100, the serum sodium is expected to decrease by 1.6 to 2.4. So if I have a patient who has a blood glucose of, say, we'll call it 200 for easy math, and they have a serum sodium of 133, technically, right, that's low sodium, right? 133 is less than 135. Their blood glucose is 100 over 100, right? Because they're at 200. So really, I can just add 1.6 to 2.4 to my 133, and right in the middle of 1.6 and 2.4 is 2. So I just add 2 to 133. Okay, and that puts me, my serum sodium is now right back at like the low end of normal. Okay, so I account for that elevated glucose causing a hypertonic hyponatremia. Okay, other things that could cause this are mannitol. So remember, that works in the proximal convoluted tubule of the nephron. And we have glycine that's sometimes used in neurological procedures, and radiocontrast. Okay, so some like follow-up questions. I already told you where mannitol worked. That's just a good one to remember. Remember, that's really good for reducing intracranial pressure too, along with like acetazolamide sometimes. So remind me again about the pathophysiology of type 1 versus type 2 diabetes. So think about that for a second. So remember, type 1 diabetes is going to be the autoimmune destruction of your pancreatic beta cells. Type 2 is going to be insulin resistance due to beta cell dysfunction. And so insulin resistance usually stems from some sort of destruction or abnormality in the insulin receptors. Remember, those are tyrosine kinases. They need insulin to bind. They will cross-dimerize and then send intracellular signaling. Usually, they believe it has to do with like fatty acid deposition that's destroying or altering the sensitivity of these receptors. So insulin levels in type 1 are going to be really low or absent, and insulin levels in type 2 diabetes are initially going to be high, and they're later going to decline. So I like to think about it kind of like heart failure. When you have a patient with heart failure initially, those myocardial cells are going to do whatever it takes to keep the cardiac output going, right? They're going to hypertrophy and go, and keep that cardiac output up while the heart is slowly starting to fail. It's the same thing with type 2 diabetes. Is when the blood glucose starts elevating, the pancreatic beta cells are going to do whatever it takes to get more and more insulin out to drive that glucose into the cells. So remember, my cells aren't responding fully to insulin, so it's going to have to keep driving that insulin up to keep the blood glucose levels stable. Eventually, just like in heart failure, the heart cells can't hypertrophy anymore and they start dying out. So here in type 2 diabetes, eventually we'll get to the point where the beta cells can't hypertrophy anymore. They can't make any more insulin and they poop out too. So mechanisms like type 1 diabetes, it's thought to do to like anti-glutamic acid decarboxylase enzymes or antibodies. Another classic disease that's associated with that antibody is stiff person syndrome. So that has to do with destruction of your GABA producing interneurons, right? So if I reduce my GABA interneurons, then I have nothing to inhibit acetylcholine from getting released at the neuromuscular junction, and it just puts me in like a tonically contracted state. I think about it very similar to the pathophysiology of tetanus, okay? That's just like a little integration there. Type 2 diabetes, we just have the impaired glucose uptake. Onset for type 1 diabetes is going to be like childhood, early adolescence. In type 2, it's usually adulthood, but now we're starting to see more and more kids be impacted with type 2 diabetes. And then we can just kind of think about like ketosis versus in DKA. That's common in type 1 diabetes because they have a lack of insulin, and insulin normally would inhibit ketogenesis. In type 2 diabetes, it's pretty rare because they'll usually have some bit of insulin to inhibit the production of ketogenesis. You might see a hyperosmolar or hyperglycemic syndrome. So I want you now, that was hypertonic hyponatremia. So again, the major cause is going to be hyperglycemia. Don't forget about mannitol, glycine, radioiodine contrast. Now I want you to think about what are the major causes of isotonic hyponatremia. So again, that would be like a serum tonicity between 280 and 295. So that's going to be our elevated protein levels and elevated triglyceride levels. So elevated protein levels, I want you thinking like multiple myeloma, Waldenstrom, and IVIG that we're using to treat diseases, and hypertriglyceridemia, right? We already know it's going to be like a super duper high level of triglycerides, like upper hundreds to like thousands. So like the mechanism behind this is like the too much fat or protein will displace the plasma water. If there's less water in the sample, it leads to a falsely low serum sodium level, even though the sodium concentration is really low. So it's a problem with like our detector. It's not a problem like there's actually not low sodium in the system. It's a problem with the way our lab equipment is detecting them, is detecting the sodium level. So let me give you a like clinical example. We have a 65-year-old woman. She presents with low back pain, a calcium of 12, hemoglobin of 10, creatinine of 1.8, which is above her baseline of 1. She has a glucose of 200, a sodium of 133. The PTH is low. Vitamin D is within normal limits. The PTHRP is undetectable. What is the next best step in workup? So in this case, right, first step first, we should calculate the serum tonicity, which is 277. So it's a little bit below that 280 that we talked about for a cutoff. But remember, like these are like more or less like arbitrary numbers. It's close enough for me to consider both a isotonic and hypotonic situation here. But when I put the full clinical picture together, I look at this, and this case is screaming multiple myeloma. I have my classic crab symptom: hypercalcemia, renal insufficiency, anemia, and bone lytic lesions and back pain. So again, the reason I made in this case the serum tonicity a little bit lower than the 280 is because I'm trying to teach you to not just like rote memorize stuff, okay? Anyone can memorize serum tonicity less than 280 can be considered hypotonic. Anything between 280, 295 isotonic, above 295 would be hypertonic. But sometimes in real life and on exams, like things don't always add up, and you actually have to critically think a little bit, okay? And I've actually seen some sources, most sources will say less than 280 is considered hypotonic, but I've actually seen several sources that also list less than 275. So it really depends on which source you're reading. And again, let's put the clinical piece together. So in this case, I'm suspecting multiple myeloma. I've got a very high clinical suspicion these excess plasma proteins can lead to pseudohyponatremia. We should get an SPEP, UPEP, and immunofixation in this patient and further work her up for multiple myeloma. So we have now talked about both hypotonic or hypertonic and isotonic hyponatremia. We are now ready to get into the big bang for our buck, the hypotonic hyponatremia. So again, in my image here, right, we take hyponatremia, we break it down into hypertonic or isotonic, we break it down into hypotonic. Those are our kind of our two branches, right? First step first, calculate the serum tonicity. Don't always just go straight off the serum tonicity, but it's a good starting point to push me into one direction or not. Look at the full clinical picture, and that'll get us pushed into the right direction. So what should we do next in the workup of our patient with confirmed hypotonic hyponatremia? So in this case, we're going to want to do a physical exam, and we're going to maybe potentially get a serum uric acid, and I'm going to explain why. So in physical exam world, right, we can break us down hypotonic further into, are they hypovolemic, are they euvolemic, or are they hypervolemic? Okay. So I want to talk about serum uric acid, which I've got on the next slide. So we'll talk about that now. But I want you to just really quick think about what physical exam findings might point me more towards hypovolemia versus hypervolemia. And then how do you think the serum uric acid might differ when you have a patient who has euvolemia versus a patient who's either hyper or hypovolemic? So take a second, think about those, pause the video. So some signs and symptoms of hypovolemia would be like our dry mucous membranes, the decreased skin turgor. So like you might see like skin tenting. We have orthostatic hypotension, right? So an SBP dropping by more than 20 when the patient moves from sitting to standing, like things like that. Tachycardia, flat neck veins. In hypervolemia, we have peripheral edema, pulmonary crackles, JVD. We could have the hepatojugular reflex, right? Where I press down on the liver when my patient's at 45 degrees and we see the elevation of the jugular vein. We could see S3 in heart failure. We might also see weight gain and ascites, okay? So that one like was the easy one. Thinking about the uric acid is a little bit difficult. When I have a patient who is hypervolemic, like clearly hypervolemic, it's pretty easy to tell them from a patient who's clearly hypovolemic, right? Even as a med student, you should probably be able to like tell this. It's very difficult for even a trained clinician to be able to differentiate, are they hypervolemic from euvolemic or euvolemic from hypovolemic, right? Because sometimes it's just very hard to tell. So the serum uric acid level can be very helpful here. Most of the literature uses a cutoff of 4 as like the threshold we're going to use here for this schema. So if the patient is hypo or hypervolemic, the serum uric acid is usually above 4. The mechanism behind this is because there's a lack of effective arterial blood flow. So in hypovolemia, it's just due to a lack of forward flow of blood. We have less blood in the system. In hypervolemia, it's also due to a lack of forward flow of blood. Maybe because my heart's not working as well. Maybe because I'm losing albumin in my urine from like nephrotic syndrome. Maybe I have cirrhosis and I've lost oncotic pressure that way because my liver's not making albumin. So in either case, the GFR is going to be low, okay, because there's less forward flow to the kidney. And in this case, the proximal reabsorption is going to be high. My kidneys are going to try to hold on to as much as they can, okay? So in this case, if the GFR is low and the proximal reabsorption of things that are renally excreted, uric acid is massively renally excreted, its levels should be pretty high in our system. That doesn't necessarily mean they have to be above the normal level, but they'll be above 4, okay? So again, in hypovolemia and hypervolemia, lack of forward flow leads to lower GFR and increased proximal reabsorption of serum uric acid. My serum uric acid level should be above 4. In euvolemia, the serum uric acid level should usually be below 4. This is because we have either we're euvolemic and we have all this increased water reabsorption from ADH usually being elevated, and it will lead to an increased excretion of uric acid via natriuresis, okay? So in this case, when you have a patient, like you can consider, why would a patient with SI-ADH even be euvolemic in the first place? Well, we're going to talk about ADH coming up in a big time, but when ADH does its work, okay, and I'll leave the mechanism for a little bit. When it doesn't work, we get more water reabsorption, It will lead to more water making its way back to the heart. My atria and my ventricles stretch. We release ANP and BNP. Those go down to the kidney. They cause afferent arterial dilation, and it's going to increase my GFR, and it's going to help us pee out a lot more of this uric acid. Okay, so long story short, in hypovolemia and hypervolemia, there's less forward flow of blood, the GFR is low, the proximal reabsorption of uric acid is high, so my serum uric acid should be above 4. In euvolemia, there's more excretion of uric acid, and the GFR is higher, so my serum uric acid should be less than 4. Okay, a good cutoff point, and a good piece of information you can get if you're working up a patient for hyponatremia and it's tough to tell, are they euvolemic, are they hypovolemic, are they euvolemic, or are they hypervolemic? All right, we will keep moving. So once a diagnosis of hypotonic hyponatremia is made and the physical exam is performed, and we get the serum uric acid, maybe we don't, the next step we want to do is we want to obtain urine osmolality and urine sodium. So in hypovolemic and hypervolemic hyponatremia, the urine osmolality should pretty much always be greater than 100. Okay, in this case, there's a lack of forward flow making its way to the kidney in both hypovolemic and hypervolemic for the reasons I talked about on the previous slide. There are 3 things that stimulate the RAS system. It's low forward flow, low sodium chloride, and increased sympathetic activity via beta-1 receptors. In this case, there's low forward flow. The RAS system is going to be sky high. And in this case, the aldosterone is going to cause the holding on to water. And so does Ang2, right? So those are both going to help us hold on to sodium and water, right? That's exactly what they do. Aldosterone holds on to sodium and water. It removes potassium and H+. And in this case, if we have low blood volume, ADH should be high, and ADH will also cause the reabsorption of water. And again, ADH is going to cause the movement of aquaporins in the distal convoluted tubule and collecting duct over, and we're going to get reabsorption of water, but we're not going to get reabsorption of solutes, okay? So in this case, the urine osmolality, we're reabsorbing a lot of this water and a lot of these solutes, and with ADH being really high in this case, we're absorbing more water than we are solutes, and therefore, the urine osmolality should be greater than 100. 100 is the classical cutoff, okay? Euvolemia is a little bit more nuanced, so we're going to talk about that coming up. But in hypo and hypervolemic hyponatremia, when we have a lack of forward flow, ADH is going to be really high, my RAS system is going to be really high, and we're ultimately going to get the reabsorption of more water than solutes because of our ADH, okay? And it's going to leave more of those solutes in my urine, so my urine osmolality should be greater than 100, okay? So we can further break down hypovolemic hyponatremia into extrarenal and renal causes of hyponatremia. We use a urine sodium cutoff of 40. Do you think urine sodium will be greater or less than 40 in renal causes of hypotonic hypovolemia, or will be greater or less than 40 in renal causes of hypotonic hypovolemic hyponatremia? So think about it. If we're talking about renal causes, is my urine sodium going to be higher or lower than 40? So in renal causes of hypotonic hypovolemic hyponatremia, the urine sodium is typically greater than 40. In this case, it's because the kidneys are losing sodium inappropriately. So if we have a patient who has a serum sodium of less than 135, their serum tonicity is less than 280, and their urine osmolality is greater than 100, we're all pointing towards hypotonic hypovolemic hyponatremia, exactly the reasons we've talked about, okay? Then we look at their urine sodium, right? If their urine sodium is greater than 40, we're like, this is likely due to a renal cause because we're dumping sodium into the urine, okay? Our kidneys should be holding on to sodium at this point. The fact that they're not is telling me that the kidneys are damaged or something is damaging the kidney, something is messing up with the way my tubules should be working, and we're dumping sodium into the urine, okay? Whereas if we have the exact same labs, the serum sodium is less than 135, serum tonicity less than 280, the urine osmolality is greater than 100, but now their urine sodium is less than 40, this might be more likely due to an extrarenal cause. In this case, it tells me that the kidneys are able to effectively hold on to sodium, right? Our kidneys sense, hey, there's a low serum sodium. They should do everything in their power to hold on to that sodium. And in this case, if the urine sodium is less than 40, it tells me they are. So now let's consider these causes. So again, here's our framework. We have hyponatremia. We've talked about the hypertonic, isotonic. We've talked about the hypotonic, and we've broken it down by physical exam. So now we're talking about hypovolemic renal versus extrarenal. So now renal causes, right? So again, serum sodium's low, serum tonicity less than 180 or less than 280, whereas a urine osmolality of greater than 100, because ADH is going to be activated, we're going to be reabsorbing water, leaving a lot of my solutes into the urine. So the urine osmolality is high, and our urine sodium is now greater than 40. That tells me it's a renal cause, and the main renal causes you want to know are going to be diuretics, primary adrenal insufficiency, and cerebral salt wasting. So diuretics, like especially thiazide diuretics, we're going to have a lack of effective arterial blood flow when we're using diuretics for a long time. And thiazides in particular impair their ability to make dilute urine. This could happen with any diuretic, but thiazides are like the big culprit. So it's an inability to make dilute urine and a lack of forward flow. And primary adrenal insufficiency, a lack of cortisol allows antidiuretic hormone to run free. Cortisol normally inhibits antidiuretic hormone. In primary adrenal insufficiency, we get destruction of the adrenal gland itself. We damage the glomerulosa fasciculata reticularis and even potentially the medulla, right? And so in this case, we're losing aldosterone, cortisol, androgens, and then the medulla would be norepinephrine, epinephrine, if we're just trying to be complete. So if we're losing cortisol, we're losing our inhibition of ADH. ADH is able to run free. In the other case, too, if we're losing aldosterone, that's also going to lead to low effective arterial blood volume, because what does aldosterone do? Again, it helps us hold on to sodium and water. If we don't have aldosterone, it's very hard to hold on to sodium and water. Again, these are some of the big mechanisms why a patient with primary adrenal insufficiency will have like a blood pressure of 80/40 on presentation, right? And remember, cortisol helps sensitize my vascular endothelium to the alpha-1 receptors, right? It tells my alpha-1 receptors, hey, be receptive to norepinephrine and epinephrine. If I lose cortisol, we don't get that, right? So you'll get a patient, classic clinical vignette or in real life, who has a blood pressure of like 80/40. We give them fluids, we give them pressors, and they're not responding. In that case, we need to consider this is adrenal insufficiency. Let's give them high-dose IV hydrocortisone, because hydrocortisone has both mineralocorticoid and glucocorticoid properties, right? I'll talk all about this when I do my adrenal insufficiency lecture. The last one you want to consider about for renal wasting of hypovolemic, hypotonic hyponatremia is cerebral salt wasting. The mechanism is still not clearly understood, but it's some sort of CNS injury leads to our natriuretic hormone release and reduced renin-angiotensin system. That leads to a renal sodium loss, overall hypovolemia, which is going to cause the release of ADH, and then we get hyponatremia. So again, I'm going to tell you like the two major ones you're going to want to know for renal sodium loss. So again, serum sodium less than 135, serum tonicity less than 280, urine osmolality over 100, and a urine sodium greater than 40 should all key me into hypovolemic, hyponatremia. And remember, I taught you serum uric acid would likely be greater than 4 in these patients, or on physical exam, right? They have dry mucous membrane, skin tenting, things like that. We should consider in that case diuretics and primary adrenal insufficiency. Don't forget about cerebral salt wasting, but less likely to be tested. If it's extrarenal, so again, serum sodium less than 135, serum tonicity less than 280, urine osmolality greater than 100, serum uric acid greater than 4. But in this case, the kidneys are appropriately holding on to sodium, so my urine sodium is less than 40. We want to consider low oral intake and GI losses, so things like vomiting and diarrhea. So in this case, a lack of forward flow is going to do exactly what we've talked about further on, like or prior in the lecture. But in this case, my kidneys are not impacted, right? It's not a diuretic problem. We haven't lost aldosterone. We are just have a less forward flow of blood. So the kidney tubule system is working totally fine. It's going to hold on to urine sodium. All right, we'll keep it moving. So how can we further break down euvolemic hyponatremia? So take a second to think about that. So in this case, we can think about, is it ADH or vasopressin dependent, or is it vasopressin pressin independent? And we'll talk about these on the next slide. So to tell them apart, right? Is this ADH dependent or is this ADH independent? Urine osmolality and urine sodium are going to tell me everything I need to go know again. Okay. So if this is an ADH dependent process, again, ADH is going to cause the aquaporins to move. We're going to reabsorb water and we're going to leave a lot of my solutes in the urine. Okay. So the urine osmolality will be greater than 100 if this is an ADH dependent cause of euvolemic hyponatremia. If it's an ADH independent cause and ADH is appropriately suppressed, right? Because remember, when serum sodium is low, it should be suppressing the release of ADH. So when ADH is appropriately suppressed, there's no translocation of those aquaporins. A lot of the water stays in my tubule system and it really dilutes out my urine. So the urine osmolality should be less than 100, right? And we can look at the urine sodium in these cases, but it's not really going to tell us too much more than we already know. So again, my patient's euvolemic, either on exam or the serum uric acid is less than 4. And we see, okay, is this an ADH dependent or an ADH independent cause, right? If the urine osmolality is greater than 100, it's an ADH dependent cause. If it's less than 100, it's independent cause. Okay, we'll keep us moving. So a massive red flag I want you guys to pick up on is if we have hypotonic euvolemic hyponatremia. So again, serum sodium will be less than 135. Serum tonicity, less than 280. Serum uric acid, less than 4. Physical exam shows euvolemia. If the urine osmolality is less than 100, which means it's dilute, that should be a major red flag, right? Because in hypovolemic and hypervolemic hyponatremia, remember, it's a lack of forward flow. ADH is going to be sky high, right? And my urine osmolality is going to be greater than 100. If we have ADH dependent euvolemic hyponatremia, ADH is high, and we're translocating and we're causing all my solutes to stay in the tubular system, reabsorbing water, so the urine osmolality should be high. So really, when I look at this, right, and I see that my urine osmolality is appropriately dilute in hyponatremia, that's like a major red flag, and it should key me in on 3 major causes. There's primary polydipsia, beer potomania, and tea and toast syndrome, right? So primary polydipsia, I want you to think about a patient drinking more water that overwhelms their kidney's ability to excrete out solutes and to excrete out water. That's going to lead to a really dilute urine. So we're just drinking more than our kidneys are able to process. In this case, I want you to look for, like, do they have underlying psychiatric issues like schizophrenia? Have they had recent stressors? Are they on any psych medications like lithium? That's also been linked to primary polydipsia. Beer potomania. Beer has almost no solute, so it's very low protein, low salt. The kidneys need a minimum amount of solute to be able to excrete water. So if we're not giving them the solute they need, then they're not going to be able to excrete water. So the water will end up building up. It will lead to diluting out our sodium in the system, and it will lead to hyponatremia. It's the same idea with tea and toast syndrome. These are usually like older individuals who can't make like food on their own. They'll just eat a lot of like poor, like low mineral diets, low mineral and low protein diets with very low solute. So again, the kidneys can't excrete water. Water builds up into the system, causes hyponatremia. So again, a patient who has hyponatremia with a urine osmolality less than 100, there should be a massive red flag that is one of these 3. These patients just have low solute, okay? All we're going to do for these patients, right, is to give them the solute they're missing. Chicken noodle soup is a great remedy for this. It's got a very high solute load. You can do that plus some fluid restriction, and it will usually clear the problem right up. And then you'll educate the patient on how to eat moving forward. If it's primary polydipsia, we'll do good old fluid restriction, and that will also help clear up the problem. So moving forward, if this is an ADH dependent cause, again, so we have hypotonic euvolemic hyponatremia. Our urine osmolality is greater than 100. Our urine sodium is greater than 40. There's another big 3 you want to consider. There's going to be SIADH. So looking at a review in the New England Journal of Medicine, some classic drugs links to SIADH that you're going to want to know are SSRIs, carbamazepine, cyclophosphamide, desmopressin, which is ADH itself, oxytocin, haloperidol, MDMA, some of our chemotherapeutics, even NSAIDs and opioids. SIADH is also linked to lung pathology. So things like small cell lung cancer that can release ADH on its own, right? So that's ectopic ADH release. We also have just classic lung pathologies are linked to an unknown mechanism to causing release of ADH. There's also the classic infection Legionnaire's disease that is linked to a hyponatremia, likely due to an ADH mediated response. So in Legionnaire's disease, you're going to want to think about a patient who has recently visited some sort of body of water. They were on a cruise, went to visit some other body of water. They were in a hot tub, a pool, weird water fountain at a hotel. They'll give you something like that. Or in real life, you ask your patient about bodies of water and things like that. They could have confusion. They could have diarrhea. They could have pneumonia, right? So it's going to be an atypical pneumonia. So you might see bilateral interstitial infiltrates. They could have hyponatremia. It's also linked to transaminitis. I've heard from multiple students that Sketchy doesn't cover that. It's a classic finding in Legionnaire's disease. Sketchy, I don't like Sketchy at all. I don't think you should use it. I think you should use some critical thinking. And so that's kind of the clinical picture of Legionnaire's disease. We treat with fluoroquinolones or macrolides. Also, we know that SIADH is linked to brain pathology. So that can lead to either an over release of ADH or actually under release of ADH and can lead to central diabetes insipidus. But so look for a patient with like meningitis, trauma. They just had recent neurosurgery. These are all classic. And remember, any kind of trauma in itself or pain or nausea or vomiting can lead to release of ADH. Other things we're going to want to consider about for vasopressin dependent euvolemic hyponatremia are hypothyroidism, especially in myxedema coma. So that's like really, really bad hypothyroidism that hasn't been treated, like these patients are on death's door. Most of the time, hypothyroidism that's well controlled or that hasn't gotten out of control to the point of myxedema coma likely won't lead to SI or to like euvolemic hyponatremia. But it's always good to check a TSH just to make sure. The mechanism behind this is due to a lack of free water clearance, so the water builds up. Secondary adrenal insufficiency can cause euvolemic hyponatremia. Remember, we talked about primary adrenal insufficiency in hypovolemic. Now we're talking about secondary adrenal insufficiency in euvolemic hyponatremia. So in this case, remember, secondary adrenal insufficiency is a problem in my brain, either my anterior pituitary or my hypothalamus. So the anterior pituitary making ACTH, my hypothalamus making CRH. In this case, we don't have the signal down to my adrenal gland. My zona fasciculata is not going to make cortisol. But remember, the glomerulosa is stimulated by the renin-angiotensin system, right? So Ang2 is going to be the stimulus to release aldosterone, or one of these stimuli to release aldosterone. So in a patient with secondary adrenal insufficiency, where their adrenal glands are totally fine on their own, they're just not getting the signal from the brain, the aldosterone should be normal. Aldosterone should be able to hold on to sodium and water, kick out potassium and H+, and my patient should be able to maintain a euvolemic state. Unlike primary adrenal insufficiency, it's an actual destruction of the adrenal gland. So it's usually due, again, to like autoimmune destruction, 21-hydroxylase. TB is a common cause overseas. In that case, we lose both cortisol and aldosterone. The patient's not able to maintain euvolemia, and they'll become hypovolemic. So in secondary adrenal insufficiency, we'll want to get a 0,800 cortisol. We're going to reflex that to a concentropin test if abnormal. Again, I'll talk about this in my adrenal insufficiency lecture. And I talked about why it maintains euvolemia. So ADH dependent. So again, we're in a hypotonic euvolemic hyponatremia. We talked about if the urine osmolality is less than 100, that's an appropriate inhibition of ADH. We want to think about primary polydipsia, beer potomania, tea and toast. If the urine osmolality is greater than 100, now we want to think about SIADH, hypothyroidism, and secondary adrenal insufficiency. So let's keep moving. Now we're into the hypervolemic gland, right? So we already talked about physical exam findings. We talked about how the serum uric acid could be greater than 4. We can now further break down hypervolemia or hypervolemic hyponatremia into renal problems and extrarenal problems. Okay, so again, we're using a cutoff of like 40 to tell the difference in the urine sodium. Okay, and we'll kind of explain that again. It's using the same mechanism we talked about in the hypovolemic portion of this talk. So Nephrotic syndrome, that's kind of a weird one to kind of conceptualize. How can nephrotic syndrome cause hyponatremia? Remember, nephrotic syndrome is defined as a proteinuria greater than 3.5 grams over 24 hours. When albumin gets really low, like less than 2, we lose intravascular volume. There's less volume in the system. ADH gets released, okay? And ADH will get released. It will cause hyponatremia. But the key here, though, this is where kind of things can get a little murky, is nephrotic syndrome is a renal cause. So like if you see in our framework, we're putting nephrotic syndrome as a renal cause. The problem is nephrotic syndrome at its core, the pathophysiology, it's destruction of the glomerular basement membrane and the podocytes. The tubular system is usually intact in nephrotic syndrome. So the tubules are able to hold on to sodium. So in this case, there's a lack of forward flow. It's hypervolemia, right? So remember, a lack of forward flow is going to stimulate ADH. My urine osmolality should be greater than 100 because ADH is causing us to hold on to all this water. A lot of my solutes will stay inside the tubular system. But in nephrotic syndrome, yes, it's a renal cause, but the tubular system is A-OK. So the kidneys are able to appropriately respond and hold on to sodium. So the urine sodium is classically less than 40 in these patients, okay? So it's a little bit tricky there. I also wanted to bring up, like when we're thinking about heart failure, so hypervolemic, hyponatremia, and heart failure, diuretics are going to be our go-to for treating these patients. Loop diuretics reduce our preload. They relieve our volume overload. So again, the loop diuretics are going to reduce the intravascular volume load. It's going to help draw in water or fluid from places it shouldn't be, like the lungs or our peritoneal cavity and ascites, and help bring that back into the intravascular space, bring it back, and then keep perfusing the kidneys. When I bring in more intravascular volume, that will help decrease the release of ADH and will hopefully help regulate my serum sodium levels. The treatment for cirrhosis. So remember, cirrhosis has a couple different mechanisms here. Low albumin in itself is going to lead to a lack of oncotic pressure and then potentially third spacing of fluids. Cirrhosis will also likely lead to splanchnic vasodilation. So we get portal hypertension, so backflow of blood through the portal venous system, and we're going to vasodilate, like these vessels are going to get really big. When the liver is cirrhotic, it can't break down nitric oxide. Nitric oxide is also going to vasodilate a lot of these vessels. And so a lot of our blood flow is just pooling in these splanchnic vessels. And then again, there's a lack of forward flow then. The treatment for our cirrhotic hyponatremia gets a little more dicey. It's not as clear cut. I put them at the end of our lecture, and I'll just briefly talk about them because it's not going to be tested on USMLE step 1 or step 2. So it's not really worth our time. But we'll go over that briefly at the end. I do want you to consider, though, when we're talking about heart failure, what are the 4 pillars of GDMT for heart failure with reduced ejection fraction? So take a second and think about those. So our 4 pillars are our ARNIs, so that's sacubitril plus valsartan. Along in that pillar are also ACEIs and ARBs. ARNIs are the preferred drug. ACEI and ARBs are acceptable. Remember, we don't combine them because when we combine them, we can cause damage to the kidneys. We can cause hyperkalemia that can further damage the electrical system in our heart. Our second pillar are beta blockers. So there's 3 very specific ones. There's carvedilol, metoprolol succinate because it sucks to have heart failure, and bisoprolol. There's mineralocorticoid receptor antagonists like spironolactone and eplerenone. And then there's SGLT2 inhibitors like empagliflozin and canapagliflozin. So those are our 4 pillars there. Remember, reduced ejection fraction is usually considered less than 40%. To calculate my patient's ejection fraction, we take the stroke volume divided by the end diastolic volume. I have other lectures on heart failure too, so we'll go over those then. So when I am considering hypertonic or just in general hyponatremia, there's a normal framework, and I'll just run back to because when we talked about like the renal and extra renal, I guess I didn't like further clarify. But when I think about renal, right, if my tubular system is malfunctioned, like in renal failure, the urine sodium should be greater than 40. When I think about extrarenal, right, my kidney tubular systems are totally fine. So the urine sodium should be less than 40. We should be holding on to it. Nephrotic syndrome, yes, it's a kidney problem at its core. The tubular systems are fine. So the urine sodium should be less than 40 in these patients, okay? And we're going to run through it all here. So here's like my overall framework. Like here's like, all right, you made it through this whole lecture, 45 minutes. What do I want to get out of it, right? Can you summarize everything you said? So again, we're going to confirm the hyponatremia. Is it less than 135? We're going to calculate the serum tonicity. 2 times sodium plus glucose divided by 18. We're going to put this into, is it hypotonic, less than 280? Is it isotonic, 280 to 295? Is it hypertonic, greater than 295? Again, remember, there's a little bit of wiggle room here. Use your actual clinical critical thinking skills to make the final push of where you're going to go with this, okay? If it's hypertonic, your working differential should be mannitol, hyperglycemia, glycine, or radioiodine contrast. Get the patient's history, right? Get a blood glucose level, right? We can see right off the bat there. Remember, if it's hyperglycemia, for every 100 grams of glucose above 100, we just add 1.6 to 2.4 to our serum sodium, right? So 2 is right in the middle of that. If we are isotonic, so 280 to 295, I want you to consider elevated proteins like multiple myeloma, Waldenstrom, IVIG. If there's elevated lipids, right? So elevated triglycerides, right? Easy labs, triglyceride, easy thing we can get. The multiple myeloma workup is a little bit more complex, right? We talked about getting the SPEP, UPEP immunofixation on those patients, right? If they are hypotonic, that's where the meat and potatoes of this lecture was, conduct a volume exam. Are they hypervolemic? Are they euvolemic? Are they hypovolemic? Also consider getting a serum uric acid, right? On top of that, we'll order a urine osmolality and a urine sodium, and this should help put the full clinical picture together. So if they are hypovolemic and their serum uric acid is greater than 4 and their urine osmolality is greater than 100, then we just need to look at the urine sodium, right? If the urine sodium is less than 40, it tells me it's an extrarenal cause. It tells me our kidneys are appropriately holding on to sodium, and we should consider GI losses and potentially low oral intake, right? The patient will come in with diarrhea or vomiting, right? I don't really need to do this whole workup. Like the whole workup will confirm it, but like their history will tell me everything I need. If the urine sodium is greater than 40, well, then we need to consider diuretics and mineralocorticoid deficiency, like in primary adrenal insufficiency. Again, patient history, like look at their medication list, right? Or do a further workup for primary adrenal insufficiency, right? And again, I'll do a whole lecture on that so we can learn more about that. If the patient is euvolemic and their serum uric acid is less than 4, then the urine osmolality is going to be the key here, right? If the urine osmolality is appropriately dilute, it's less than 100, you want to consider ADH has been appropriately inhibited. Our urine, all that water staying in the tubular system, we want to consider primary polydipsia, beer potomania, and T-Intose syndrome, right? So get a further history. Does the patient have psychiatric disease? Are they heavy alcoholic, right? What are they eating on a regular basis, okay? If the patient is euvolemic, their serum uric acid is less than 4, and their urine osmolality is greater than 100, we want to consider SIADH, hypothyroidism, and secondary adrenal insufficiency. Again, look at their medications. Were they started on any new ones recently? Do they have any lung pathology? Do they have any brain pathology, right? Look at their TSH. Get a 0800 cortisol, reflex to costentropin, okay? All things we can consider. If they're hypervolemic on exam and their serum uric acid is greater than 4, then their urine osmolality should be greater than 100 because of a lack of forward effective blood flow. ADH is going to be stimulated. We're going to reabsorb all that water. A lot of my solutes stay in my kidney tubular system. We then look at their urine sodium. If their urine sodium is less than 40, our differential should include CHF, nephrotic syndrome, or cirrhosis. If the urine sodium is greater than 40, we should include, think about renal failure as our main diagnosis there. So again, I just put it into, this whole thing was from Dr. Mansour's Frameworks for Internal Medicine book. I highly recommend it. He has all these great figures, all these great chalk talks. I've kind of built my framework off of his and kind of added more clinical information as I learned from attendings and from just like other reading material. But this kind of gives you a full visual. So if you want to take a screenshot, and use it for your own. Amboss has another really good one too. But this is everything I just summarized into words. Remember, just the weird one in hypervolemia, The renal causes are renal failure and nephrotic syndrome, but nephrotic syndrome, the tubulars are normal, so the urine sodium should be less than 40, just like heart failure and cirrhosis. In renal failure, the urine sodium is usually greater than 40 because the tubular systems malfunction. So one quick word on like how do we treat these patients. This is from a New England Journal of Medicine review, a relatively new review where they kind of put everything together. So emergent treatment should be like severe or moderate symptoms. So those are going to be things like seizure, confusion, vomiting, cardiorespiratory distress. If the patient's post-op or they have intracranial disease, we're going to want to initiate 3% hypertonic saline. We're going to give them in 100 to 150 milliliter IV boluses. We're usually going to do that 2 to 3 times. Usually in between each bolus, we'll get a serum sodium level, okay? We want that sodium to go up by 4 to 6 millimoles in the first 1 to 2 hours, okay? We do not usually go past 6 to 8 millimoles, like increase in that first day. The max amount we're going to want to do is 10, okay? No more than 10. Usually 4 to 6, maybe 8, definitely no more than 10. And then we're going to aim for 18 in the first 48 hours. We really want to be careful here because if we increase the serum sodium too fast, it can cause osmotic demyelination syndrome. So like the classic mnemonic is low to high, the pons will die. High to low, the brain will blow. So high to low, the brain will blow is cerebral edema, okay? Low to high, the pons will die, osmotic demyelination syndrome. If the patient has chronic or mild causes, we're just going to fluid restrict them, right? Less than a liter per day. Other options, we can use oral sodium tablets. We can use loop diuretics, urea, and even tolvaptan, which is an anti-ADH. We don't use that in liver disease because that can further damage the liver. But again, really, really bad hyponatremia with seizures, confusion, vomiting, things like that. Give 100 to 150 milliliter boluses of hypertonic saline. We're going to recheck the serum sodium. We're going to want it to increase by 4 to 6, maybe 8, definitely no more than 10. And then we're going to aim for 18, an increase in 18 over the first 48 hours. If it's mild, we're going to fluid restrict, and then maybe we've got a few other tricks up our sleeves, like sodium chloride tablets, loop diuretics, urea, and tolvaptan. Just on 28, if you wanted to take a picture, if you like it more in like pictures, you can take a screenshot of this. It's just the exact same things I said and put into picture form. This should say 10 millimoles in 24 hours, not 244 hours. Okay. One final point here is there's something called the 0.9% normal saline challenge. The goal here is to also help us differentiate hypovolemic hyponatremia from SIADH in a patient who has stable hypotonic hyponatremia. All we do here is we infuse 1 to 2 liters of 0.9% normal saline, and we look at the serum sodium, right? So if their sodium goes up after I gave them the normal saline, we interpret this as the patient was hypovolemic. How does this make sense? If we give them the fluid they were missing back, they now have their intravascular fluid is restored, and that should decrease the production of ADH, right? Because remember, the 3 things that stimulate ADH are high serum tonicity, low blood volume, pain, nausea, vomiting. The low blood volume always wins. So if we replace the blood volume they're missing, the ADH should be inhibited, and their serum sodium should slowly start increasing, okay? If we give them the normal saline and their sodium stays flat, stays at the level it was, or even goes down, we should interpret this as SIADH, because in this case, the ADH is staying active, okay? The water's retained and the sodium stays low, right? Because in this case, ADH is being released pathologically, and us giving the patient fluid is actually only going to make things worse, okay? It's going to further dilute out the sodium. So just the key point is we only use this in clinically stable patients. If they have severe symptoms, we use that hypertonic saline I discussed previously. So I've got like a final question for you to try to put it all together. So we know nothing about the patients, about our patient here, except for these labs. So I want you to consider which of the following is the next best step in determining the etiology of the patient's hyponatremia. So there's their sodium, their potassium, their BUN, their glucose, their urine osmolality, urine sodium, and their serum uric acid. So use everything I taught you in this lecture. I would suggest pausing the video. Take as much time as you need. I gave you A through G, so it's a tough question, and consider what you would do. So in this case, we're going to want to get a psychiatric history, a dietary history, and alcohol use. If you do the whole workup, we find out the patient has hypotonic hyponatremia. Okay. They look euvolemic. Okay. Well, I didn't really give you a physical exam, but the thing that pointed me to euvolemia is the serum uric acid is less than 4. Okay. So I'm now hypotonic. I know my serum uric acid is less than 4. So that kind of helps me rule out hypervolemia and hypovolemia. So I'm stuck in my euvolemic category. Now remember our workup. If they're euvolemic hyponatremia, we want to consider, is this ADH active or is this ADH inactive? Okay. We look at their urine osmolality and their urine sodium, and they're both really dilute. Okay. That, remember, that was that major red flag I told you about. In this case, ADH has been appropriately suppressed. So what were the 3 big things I told you that would appropriately suppress ADH in euvolemic hyponatremia? That's primary polydipsia, beer-potomania, and tea and toast. So the correct answer would be F. We'd look for a psychiatric history, dietary history, and alcohol use. We can treat them with giving them the proper diet or restricting their fluids or both, right? And that will help clear things up. This was just the real brief correcting hyponatremia and cirrhosis. So again, from the New England Journal of Medicine, I will paste below this video the, I think it's important for you to have the journal article about like correcting hyponatremia. I don't think the cirrhosis one is as important, but I'll give you the hypertonic saline article so you can have that on rounds if you want it. But we can use fluid restriction, we can use sodium chloride supplementation, urea, and tolvaptan again for correcting hyponatremia in cirrhosis. This was a lot. So like I have practiced this schema like probably a couple hundred times, honestly. Practice it, see it in real life and practice the workup. And you'll get really good at it. But again, like really quick, we get their serum sodium is less than 135. I calculate their serum tonicity 2 times sodium plus glucose divided by 18. That puts me into hypotonic, isotonic, or hypertonic, right? If they're hypotonic, I'm going to want to do a physical exam. I'm going to want to get a serum uric acid. I'm going to want to get a urine osmolality and a urine sodium, and that's going to point me into the right direction. Doing a good history and a good physical exam are going to be key here. Really, at the end of the day, right, if the patient is severely ill, like they have seizures, confusion, cardiorespiratory distress, we're just going to treat them with the hypertonic saline. If they're not, it's fluid restriction. And so like really like the treatment like would be a lot of the same. But if we can determine why was this patient hyponatremic in the first place, we can potentially find the underlying problem and help treat that as well. So that's why this whole workup is key, and it's classically tested on the USMLE. So there's my email. If you have questions, let me know what else you want to be covered, and I'll do it. All right.